Every morning, Robert Haynes woke up and took 3 pills: antihypertensive, statin, 81 milligram aspirin, a 40-second routine he repeated every day for 12 years without fail. The cardiologist had prescribed the aspirin right after the stent in 2011, and Robert had decided right there in the office that that white pill, the size of a fingernail, was what was keeping him alive. He was right. The aspirin protected his heart. What nobody told Robert, what no package insert clearly communicated, what no follow-up appointment verified in 12 years, is that that same pill was destroying his stomach, silently, progressively, with the patience of something that knows it has time because you'll take it again tomorrow morning. On the morning of October 2023, Robert went to the bathroom at 6:40 a.m. as he always did. He didn't return to the kitchen. His wife Carol found him kneeling on the floor with blood on his hands and a specific expression on his face. Someone who couldn't understand what was happening because, until that moment, he felt absolutely nothing. 12 years of silent destruction, and then, all at once. Aspirin doesn't warn you while it works. It doesn't hurt. It doesn't inflame anything that shows up in routine blood tests. It doesn't produce symptoms in the first weeks, the first months, the first years of use. It simply appears every morning small, white, harmless in the palm of your hand, and silently performs the same process it did the day before. Only, each passing day, the accumulated damage grows a little more, like water on a stone, like time on a foundation that no one inspects. Acetylsalicylic acid enters the bloodstream and irreversibly deactivates an enzyme called COX-1 in the cells lining the stomach. This enzyme is responsible for producing the mucus that protects the gastric wall from the very acid that the stomach secretes to digest food. Without the mucus, the stomach wall is exposed, and the acid which keeps being produced, which no aspirin in the world can shut off slowly, begins to digest the very organ that contains it. It's erosion, it's progressive, and it's silent in 70% of cases because the gastric mucosa doesn't have the same pain receptors as the skin. You don't feel the stomach being corroded layer by layer. You feel it when the corrosion has already penetrated the entire wall. That's how Robert felt it, on the bathroom floor. After 12 years of taking the medication, the doctor said was for him to live longer. What the medical literature documents about the proportion of chronic aspirin users who develop significant gastric lesions without any prior symptoms will permanently change how you understand the phrase low dose, low risk. But the mechanism by which aspirin produces fatal gastrointestinal bleeding in patients who have never felt anything at all in their stomach is the detail that no package insert communicates with the clarity it should, and that most doctors who prescribe it don't actively monitor because cardiology protocol doesn't require them to ask. Robert was 63 years old, with controlled hypertension, slightly elevated cholesterol, and a coronary stent placed in 2011 after a mild heart attack. No history of gastrointestinal disease, no diagnosed ulcer. No digestive complaints at any of the previous 12 follow-up appointments. In January 2023, he went to his annual cardiology appointment. The doctor reviewed the electrocardiogram, the echocardiogram, the lipid profile. Everything was within the expected parameters for a well-controlled patient with a history of coronary events. The appointment lasted 22 minutes. The cardiologist didn't ask about gastrointestinal symptoms. Robert didn't mention anything because there was nothing to mention. He felt absolutely nothing in his stomach. And it was in that office, in that 22-minute silence, that the window between what could still be reversed and what was beyond repair shrank by a year. There were 2 options at that moment. The first was to maintain the current protocol, 81 milligrams of daily aspirin without gastrointestinal monitoring, next appointment in 12 months. The second was to do what the American Gastroenterological Association guidelines have recommended since 2017 for patients over 60 years old on chronic aspirin use. Co-prescription of a proton pump inhibitor for gastric protection and surveillance endoscopy every 2 to 3 years. The cardiologist chose the first option. It was what he had always done. It was what most cardiologists do. The gastroenterologist was never consulted. Robert left the appointment with the renewed prescription and went home to take the aspirin the next day. In 2019, researchers at Harvard Medical School, led by Dr. Andrew Chan, published in the New England Journal of Medicine an analysis of 19,114 participants in the ASPREE study, the largest randomized clinical trial on low-dose aspirin in elderly individuals without prior cardiovascular events ever conducted. The data were straightforward and disturbing. Participants taking 100 milligrams of aspirin daily had an 87% higher risk of clinically significant gastrointestinal bleeding compared to placebo. In participants over 70 years old, the risk of fatal bleeding was 2.3 times higher than in the group that took nothing, 87%, at a dose of 81 to 100 milligrams, the dose that 48 million Americans take every morning thinking it's safe. And here's the detail that turns statistics into accusations. Most of the participants who developed significant gastrointestinal bleeding in the study had no prior detectable symptoms. They were fine at follow-up appointments. They reported feeling well, and then they bled. Exactly like Robert. Because aspirin doesn't warn you, it never warned you. And the healthcare system has built a protocol that doesn't require anyone to ask. But the most disturbing data wasn't in the Harvard study. It was elsewhere, and it took years for someone to connect the dots correctly. In 2017, Dr. Lauren Lane, a gastroenterologist at Yale School of Medicine and one of the world's leading experts on gastrointestinal injury from anti-inflammatory drugs, published a systematic review in the American Journal of Gastroenterology documenting that chronic use of low-dose aspirin produces endoscopically detectable gastric ulcers in 15% to 20% of users after 6 months of continuous use. In users with more than 10 years of use, this proportion rose to between 25% and 35%. 1 in 3 long-term chronic users with ulcers that nobody was looking for. And the mechanism that made it all worse than it seemed was twofold. Aspirin not only removes the protective mucus from the gastric wall, it also inhibits platelet aggregation, the ability of blood to clot at points of injury. What this means is that when the ulcer formed by the erosion of the mucosa finally reaches a blood vessel, the blood that begins to leak doesn't clot with normal efficiency. The same molecule that protects the heart from clots prevents the stomach from stopping bleeding. The anticoagulant and the erosive medication are the same pill, taken every morning, with the cardiologist's blessing. Without the gastroenterologist's knowledge, Robert arrived at St. Joseph's Hospital in Phoenix at 7:15 a.m. blood pressure collapsing, 82/50, hemoglobin 5.8 grams per deciliter, less than half the normal value for a man his age. He had lost approximately 40% of his blood volume from the perforated ulcer that had been bleeding for hours while he slept. The emergency team tried to stabilize him with transfusion and intravenous fluids while preparing for an urgent endoscopy. The gastroenterologist who attended him, Dr. Michael Torres, 47 years old, 20 years of experience, looked at the endoscopy image and then at Robert's medical record: 12 years of aspirin, 0 proton pump inhibitors, 0 surveillance endoscopy. 0 gastroenterology consultations in the entire documented medical history. Torres had seen this before, not in that specific patient, but in that pattern, many times. And the instinct that Robert's cardiologist had followed in 2011 prescribing aspirin to protect the heart without establishing a joint protocol with gastroenterology to protect the stomach was not an exception, it was the rule. What American medicine learned from Robert Haynes, from the ASPREE study data, from Dr. Lane's reviews, and from the more than 100,000 annual hospitalizations for aspirin-associated gastrointestinal bleeding documented by the CDC, is that there is a systemic gap between the cardiology protocol and the gastroenterology protocol that is costing stomachs and lives of patients who did everything right. They took the prescribed medication, they went to their annual appointments, they didn't miss a single day, and the system didn't build a bridge between the two specialists who should be talking about the same patient. The cardiologist thinks about the heart. The gastroenterologist thinks about the stomach, and Robert was caught in the middle with a perfectly functioning stent and a perforated stomach. What Robert never received was the information that gastric protection is a mandatory part of the chronic aspirin use protocol. This information has been in the medical literature since the 2000s. It has been in the American Gastroenterological Association guidelines since 2017. And it didn't reach Robert's cardiologist's office during any of the 12 annual checkups he had in the 12 years he took aspirin every single day without fail. Robert survived, with part of his stomach surgically removed and a permanently altered digestive capacity. He still takes aspirin, now with omeprazole, a combination that could have existed since 2011 and only exists since October 2023 because he got to the hospital in time. Others don't. Every year, approximately 3,200 Americans die from aspirin-associated gastrointestinal bleeding, most without ever having received supplemental gastric protection, most with a cardiologist satisfied with the results of the last consultation. The heart was fine, the stomach couldn't handle it. The difference between chronic aspirin use that protects the heart and chronic aspirin use that perforates the stomach isn't the dose. It's not the brand. It's not the patient's genetics. It's a second prescription that costs less than $20 a month, and that nobody has written. Proton pump inhibitors, such as omeprazole or pantoprazole, taken along with aspirin, reduce the risk of gastric ulcers by 80% in chronic users, according to data published in the Annals of Internal Medicine in 2002, and reconfirmed in multiple subsequent studies, 80%, with a pill that any doctor can prescribe in less than 30 seconds. If you have been taking aspirin daily for more than 6 months, especially if you are over 60 or have a history of any digestive problems, ask your doctor one question at your next appointment. Should I be taking gastric protection along with aspirin? If the doctor you consult is a cardiologist, also ask for a referral to a gastroenterologist for routine evaluation. And if you've never had an endoscopy and have been taking aspirin for more than 5 years, explicitly ask if a surveillance endoscopy makes sense in your case. These 3 questions together take less than 2 minutes. These are the questions Robert Haynes didn't ask because he didn't know he needed to, because nobody said it was necessary, because the system built a protocol that protects the heart and forgot to ask what was happening to the stomach at the next appointment. 12 years of silence, 40 seconds of routine every morning, and one morning that ended on the bathroom floor with blood on his hands and a stomach that had waited patiently longer than any organ should need to wait to be heard. But aspirin isn't the only drug doctors prescribe every day for one condition that's causing silent, progressive damage to another organ without any monitoring protocol detecting it in time. In the next video, the anti-inflammatory drugs that 50 million Americans buy without a prescription every week for back pain and headaches, and what they're silently doing to the kidneys of those who use them with the frequency the label calls occasional. The name of the damage is analgesic nephropathy. The interval between the start of use and diagnosis is years. And the kidney, unlike the stomach, does not bleed to warn that it is failing.